Got to make sure we get a good chair because we're here a long time.
Good afternoon, everyone. Welcome to the working group to study payments by insurance companies for deposit into the insurance fund. This is Friday, October 4th, 2024, and we will convene the meeting. Any remarks from chairs? Vice chairs? Great. We'll jump right into the presentation by OPM, and Judy Dowd will be presenting. Judy, would you like us to go to DPH first? Yeah. Okay, great. We will just rearrange the agenda and go to item number 4 and do presentation by the Department of Public Health, and then we'll come back to OPM. Thank you. Welcome to Miriam Miller and Jody Terranova, Deputy Commissioner. Jody Terranova, please go ahead with your presentation.
Thank you. Good afternoon, members of the working group. I'm Dr. Jody Terranova, Deputy Commissioner at the Department of Public Health and a pediatrician. Thank you for the opportunity to talk to you today about the Connecticut vaccine program. Our vaccine program is funded through 2 main sources, federally through the Vaccine for Children program and the complementary Connecticut program, which is through the insurance fund that we're about to talk about today. The ability to provide vaccines at no charge to children across the state has grown over the years, and Connecticut is now the 11th universal vaccine state, meaning all recommended childhood vaccines are available at no cost to patients and providers. To provide a little bit of history, in 1993, Congress passed the Vaccine for Children Act to ensure that high-risk children had access to vaccines, and this was in response to the 1989 to 1991 measles epidemic that infected over 50,000 people and hundreds died. When CDC investigated that, they found that the reason that many of these children were unvaccinated was because of the cost of vaccines. So they worked to pass the Vaccine for Children Act to provide no-cost vaccines to children that are on Medicaid or uninsured, as well as American Indians and Alaskan Natives. Under this act, the CDC Advisory Committee on Immunization Practices votes on which vaccines to include to be covered, and then Connecticut follows that model and provides the same vaccines that VFC does. In Connecticut, VFC funds about 44% of our childhood vaccines, and so the remaining 56% needs to be funded through other sources. So today we're going to talk about how we fund that through the immunization fund. Decades ago, Connecticut started a small appropriations from the general fund to be able to provide some vaccines for free to providers, but it didn't provide access to all of the vaccines. And over the years, the amount of money that was appropriated grew, but the cost of vaccines and the number of vaccines that were available and recommended grew over time as well. So the legislature looked at other options, and in 2011, late 2011 and early 2012, there was a task force on childhood immunizations that looked at how we could develop a long-term sustainability for this vaccine program and make sure that we could work towards becoming a universal vaccine state. And it was in 2014 when the legislature passed Public Act 14-217, which shifted the program to the insurance fund and established the current model that we see today. That's our Connecticut vaccine program. So through this program, as I said, the federal government pays for all the kids who qualify for VFC, and then the state insurance fund is paying for the remainder of the children. The state is able to buy all of the vaccines for those remaining children through the CDC contract at a lower price than it would be on the commercial market. And it's through this mechanism that we're able to save insurance companies about $23 million with the price difference from commercial price for the vaccine versus the CDC federal contract price. Our vaccine program has helped Connecticut maintain our vaccine rates as one of the highest in the country. We're consistently above the national average. The national average is usually in the low 90s. Connecticut's current vaccination rate for kindergarten children is 97%. So this program helps us make sure that all children have access to vaccines at no cost and keeps our rates high. You will see in the materials we provided the budget for the immunization fund, and I can certainly answer any questions on that. I did want to tell you that in that shift in fiscal year 15, when the insurance fund moved the money out of the general fund and into this separate fund, there was about $31 million at that time that was funding our program, and 3 positions were also shifted from the general fund to the insurance fund that helped to run this program. And these are staff, 3 staff members that help process the orders that providers put in, that help do some quality assurance, that do site visits to make sure that the providers are storing vaccines appropriately and giving them to the appropriately aged children. We have a number of other staff in the immunization program that are funded through our federal contract with CDC, but we have 3 funded through the insurance fund. And then really the core rationale that we believe the reason that the insurance fund was the best mechanism to provide for the vaccine program was because of that significant cost savings that I mentioned. Just last year was $23 million for the insurance companies, and over time it remains around that amount, where if in the past individual providers needed to purchase vaccines and then bill the insurance companies would be billed that higher amount and reimburse providers for those higher dollars. So it is a cost savings to the insurance company to fund it through this mechanism where we can purchase off of the federal contract. When we purchase off of the federal contract, we do it through a bulk purchase with our vendor, which allows us to sustain a virtual inventory so that the vaccines are not physically purchased with an expiration date. So they are sitting there on hold, and then a provider puts in an order. The vaccines can be shipped right to that provider's practice each month. And so orders are placed monthly and delivered monthly to practices, but this allows us to kind of purchase a larger number each quarter and then let it sit there for providers to order what they need individually and sustain a supply. We calculate the amount of vaccines that we need each year based on a population estimate. CDC gives us the number of children eligible for VFC versus what's remaining. And then we look at the ages of those, what vaccines are recommended, what the current cost of the vaccine is, and then estimate how many of each type of vaccine we would need to order and what the cost is, and use that as our cost estimate for each year's budget. I think that's most of what I have to share right now, and certainly I can take any questions, or we can let OPM.
Great. We'll open it
Okay.
up to questions. Thank you for that presentation, Senator Austin.
Thank you. So in the last budget cycle, your budget here has right now in fiscal 25, there is no cost for vaccines. Is that, which year did we not put dollars in?
You took out some dollars last year in fiscal year 24 because we had a surplus in that virtual inventory. Part of over during the pandemic, there was less requests for vaccines, and we had built up a supply a little bit before then. And so when we looked at our numbers, we had some surplus of certain types of vaccines, so we were able to draw down rather than need to purchase some of those. So there was money held back in 24.
And so it doesn't show that on here, does it? So it says vaccines, 25 million. On the.
Yep.
And
Yeah.
So my understanding is when we were looking at it, that we took the whole, that we swept the whole program.
Yeah, no, I think you held back about 30 million. Mhm.
So it would have been 55 million.
Right, it would have been 55.
And then next year, your anticipated dollar amount is what? For
Yeah.
fiscal 25 and fiscal 26?
Yeah, for 25, I think that the current allocation was unchanged from previous, so around, I think, yeah, 65, but we'll lapse about 15 million because of that excess
Say it
inventory
again.
that we're
I'm
sold.
sorry, you were all chatting.
Yeah,
What did you say, Judy?
Oh, I said we were showing a lapse of 15 million, just what they said.
yeah.
So how much are we spending?
I don't have that exact number in front of me, I think. Let
And
me
what is your
see.
anticipated budget for the next biennium?
Yeah, I have that. The 50, yeah. Yeah, the next 2 years, I think we have for the fiscal year 26 estimate at the
trying to get
current vaccine price. So the CDC contract, of course, every year the vaccine prices change. But if we just use today's prices, we're estimating fiscal year 26 would be 52 million and fiscal year 27 would be about 55 million.
And so, relative to the 23.8 million that you anticipate the carriers save, how do you come up with that number? What is the benchmark of that number?
Yeah, so that is, and we can share the spreadsheet with you certainly, but that lists all of the vaccines, the current CDC federal contract price, and then the current commercial marketplace price. And then using the difference between those and the number of each vaccine that we would need. That's how we calculate the savings.
So, do the commercial carriers pay anything if we're paying this?
They,
amount?
they are, all aside from the assessment that they're paying for.
I'm not talking about the assessment
Is
right
the
now.
practice charging them anything? Is that your question?
Yes.
They charge them an administration fee, so they can charge like for the nurse's time to administer the vaccine. They would pay for that.
Okay.
Mhm.
So, because Representative Walker and I talk about the formula that's used, and it's kind of hard to get people to give us exact data on it. So do you have the list of the vaccines that are covered and the current cost of those vaccines? Can we
Yeah.
get that?
Yeah, absolutely. We can share the spreadsheet with you.
Because I think that would just start getting it. And you talk a little bit about us having a 97% rate of vaccines in kindergarten,
Mhm.
but you're not counting kids that are homeschooled, right?
Right.
So if you're not, so we know that there are a number of, like I go down several streets in my district and everybody in the whole street, I don't know if they moved there because of that, but they're all homeschooled kids.
Yeah.
And there's a lot of them. And so is there any calculation on how many kids are not vaccinated that are homeschooled kids?
There's not an easy way for us to capture that number. I think the way we capture the kindergarten kids is when everyone enrolls, they have to fill out that blue form from the pediatrician that has your vaccine record, and then the school nurses each fall go through those and fill out the data to let us know the vaccination rates for each of their children. So the kids that aren't in school aren't being captured that way. CDC does do a national immunization survey, which is more of not a survey of everyone, but of a segment of the population to get some estimates of what the vaccine rate is in each state. Our numbers in that survey hold steady to about what we're seeing in the kindergarten ones in those high 90s. But there's not an easy way to capture the kids that are not in school.
So those kids don't actually figure into any of the calculations
Right.
that you have.
Right.
So there could be a number of them, but you wouldn't know.
Right. At some point, I think we'll have more robust data in our immunization registry that we might be able to get better numbers. But not everyone was participating in that before. And so again, there would be a gap in those numbers.
I might have a couple of more questions, but that gets me going.
Representative Walker?
Thank you. Thank you. Thank you for your presentation. I couldn't hear half the conversation because when you're off mic, unfortunately, us on the Zoom don't hear all the exchange. So did I hear that the FY25 amount was 64 million? Was that 64 and some odd dollars million? Is that correct?
Yes.
Okay, all right. So that's 64. So it's dropped. Okay. The other question I have is that listed on your sheet, you have admin costs. So you said in 2015, you had 3 staff members. How many staff members now are we paying for out of the vaccine fund in DPH?
Just those same 3.
Just, we don't pay for any other staff members.
No, those are paid through on our federal grants.
Okay, okay. And in
Rep. Walker, one clarification, there may be other staff who are supported through other areas of the insurance fund, but we're talking about the immunization fund specifically today. So there's 3 staff on the immunization fund,
right.
but insurance fund as a whole may cover other staff time.
Okay, okay, that's, I'm glad you clarified, because that was my confusion, because yeah, thank you. So then the admin costs, the sexually transmitted diseases, tuberculosis control and then the vaccines, the other costs that are listed up here are factored into the immunization costs. Is that true?
Yeah, you're talking about the sexually transmitted disease and tuberculosis?
Mm-hmm. Yes.
Yes. In that same statute about the immunization program, there's also calls out that the department would provide tuberculosis medication and STD medications. And so we use these dollars to provide those medications to local health departments and other providers to treat patients that don't have insurance coverage or other coverage, kind of as a payer of last resort for those medications.
Okay, so any other costs that DPH has, it's not going through the immunization, and may go through another allocation of the
Correct.
insurance.
Mhm.
Okay, all right. Thank you, Madam Chair.
Eric George.
Thank you so much, Dr. Terranova. Very much appreciate that presentation. Just so you know, and you probably already know this, as the Insurance Association president, we represent the property and casualty and life insurers generally. But also, as you probably know, the definition of health insurance is rather broad under the Connecticut statutes and go beyond to just what we would consider general health insurance, extending to disability income, long-term care, certain supplemental, whether it's dental or vision, and many of our members do provide those types of coverages. So it is my understanding, they've told me, that they are assessed, obviously, on a proportional basis for the public health fee and the general welfare fee. Those who provide those types of health insurance. In terms of the vaccination, are just those carriers providing coverage for vaccinations assessed for it?
That's not a question I could answer for you. I don't know if
one
OPM
can
is
answer
able
that
to
question?
answer that.
Yes.
And how is that determined? I'm sorry, I do think that's important to know. How do you make the determination as to which company provides vaccination coverage?
Might as well come up. It's okay. You can answer the question. It's okay.
It's good to see everyone. My name is Zani Matowski. For the details of that, we'll follow up in writing on that, but the answer was yes, but we'll just follow up in writing with detail.
Okay.
So with that one,
Because what I want to drill down into, and I'm sure if you say it's yes, I'm sure you have the background for that. The justification for charging insurance companies for the vaccination program is that it saves insurance companies money. That would only be the case if the insurance companies are providing vaccinations. So I want to know precisely that only those insurance companies providing vaccinations are charged that. I do have a follow-up question though. From your, I hear justification for keeping the vaccination coverage in the insurance fund. From your perspective, if the vaccination program and other public health programs are funded, does it matter whether it is paid for through the insurance fund or the general fund? From your perspective?
Do you want me to answer that or you?
I think that's a more judgment decision that, you know, we're funded how the department's funded, how it's funded, and it's more of a judgment of the legislature to determine how they allocate the funds.
The reason I ask is because you provided justification for.
Yeah.
And so if you're providing justification for it, it would lead me to believe that it might be your preference. And if that's not the case, then please explain that.
Sure. I think we can follow up more with that one, but I think the reason we wanted to share the savings that we believe comes to insurers because of the coverage of the vaccine program. The other cost saving measure is downstream, right, with the prevented diseases, right? And so vaccine is a disease prevention strategy. With more disease prevention, you have less cost savings on the healthcare side.
Got it. And I appreciate where you guys are coming from, and I understand that it is the public policymakers that make this decision. It has been argued by me that as long as the programs are satisfactorily funded, that would be the number one, I think, mission, goal, desired result. And that's why I just wanted to find out from your perspective if there is one preference, one way you prefer over the other, and if so, why? But I understand you'll follow up with additional information, and so I'll hold off on any further questions at this time. Yeah.
So I guess, just so you know, it does remove life insurers in Public Act 12-1. So it does do that. And then on the public benefit portion, why it's in, I guess, the insurance fund, that portion, just, I think it benefits the insurers, right? It provides bulk purchasing. It provides them with the ability to have access. I think it was originally part of a negotiated thing with the insurers that this is something they looked for. So I think this.
I'll defer to
Yeah,
health
I think this
insurers
was
on
something that benefits all
It was not
parties.
negotiated with any of my clients.
Yeah, but you're not, I don't think you're assessed with it.
And that's what I want to make sure.
Yeah, so I
And
think
that's what I
that
just
that
wanna
is
make sure.
something, yeah, so that's something we'll return running, but I am 100% sure that that is the case.
Great.
Representative Nuccio.
Thank you. So I wanted to ask a couple of questions and make one clarification. Everybody keeps saying that this saves insurance companies money. It doesn't save insurance companies money, it saves the members money. Insurance companies don't exist without members. Members are the ones who are getting the charge. Members are ultimately the ones who pay the cost of the insurance product, which is the claim. So this is saving members money by saving on the vaccine cost. You're lowering the cost of care, because if a doctor charges $100 for a vaccine, say the Connecticut purchases it for $50 and it is paid for $50, it lowers the cost of care. It doesn't, insurance companies aren't saving any money because insurance companies don't buy nor administer immunization shots. Doctors do, members do, etc. So I just think we should use the right terminology here. But most importantly, I wanted to figure out, so is the federal government then paying for all of the children or adults who are receiving vaccinations that are on Medicaid, plus the Native Americans in Alaska, I think it's Alaskans also. So is the federal government paying the portion that's on Medicaid? Is that correct?
Yes, Representative Nuccio, that's correct. For the children through the Vaccine for Children program, the federal government directly covers the cost of those vaccines.
Okay. What about the state employees? Are they paying the immunization assessment also?
Oh, I don't, I'll see if OPM can answer. I don't know who pays into that. I don't know who is assessed.
If you can clarify the question, and then we'll be able to return in writing, because I don't know if we fully.
Well, typically the state of Connecticut exempts themselves from many of these like types of assessments and such. So the state employee plan, is the state employee plan also being assessed the $50 per member per year for immunizations? That commercial insurance is also being assessed, is my question. Is the state so we know Medicaid is being paid for by the federal government, and that covers people without insurance, people on Medicaid, American Indians, and Alaskans, right? So that takes care of that population. Independent commercial insurance is billed based off of their members that are situs in the state of Connecticut, right? So my question is, does the state of Connecticut employee workforce pay for their members also?
Off the top of my head, I do not know the answer to that question, but we'll check on it and return in writing. And then to your clarity on how to refer, I just want to just clarify that if the members are saving money, I do think that is good for the health insurers, because the health insurers are supposed to be providing good services to their members. So that is tied together. So if we're saving them money and then we're saving the health insurers money, they are responsible for their members, and they have an obligation also in certain respects to provide vaccines. So I think they are tied together. Fundamentally, they're not separate entities.
Well, but I can tell you for fact, you know, if I have 0 members in the state of Connecticut, I'm paying 0 for immunizations, right? Because I don't have anybody who has an insurance policy in the state of Connecticut. The savings is direct to the member. There's insurance companies, again, aren't making money off of having this pooled at the state level. Just by nature of how insurance works, the premium and the cost share is paid by the employer and the employee, right? So yeah.
So if I just wanted to say that relative to who's paying what, that's really not the people that sit in front of us today. Though that's a policy decision that we can direct to the Secretary of the Office of Policy Management when he is sitting in front of us. It makes the most sense because these are employees, not policymakers or even people that do that. So we have that on the record that is the opinion of one and the opinion of another we have on the record now, so we can bring those questions back to that. So if we could just go on to the next question, that would be helpful. Thank you.
No problem. Mine was more just establishing exactly who's paying and where it's being paid from. I wasn't aware of the federal piece, so glad to know that. And then if we can just get clarification on whether or not the state employees are also paying into this, I think that would be good. By terms of how this works,
state employees pay for their insurances like anybody else pays for insurances. And so they're paying any state employee, having been one for 21
But Kathy, this is an assessment, right? This is not a premium.
No, but the state employees are paying for their insurance, and the state of Connecticut is paying for insurance. They pay for Medicaid, the Advantage program. That is paid for by the state. And
no, I'm not disputing that, Kathy. The assessment, though, is a separate bill that is sent.
And the state comptroller is the one who pays the bills relative to the employee insurance, which is just like any other insurance. And they pay for those things also. So
that's what I want clarification on. I'd like to know that they are actually paying the assessment.
That makes that we would talk to about that. And I just want to, I don't want to vilify a whole group of people thinking that they're not paying for something. And when we say that, it sounds to the public as if state employees are getting a free benefit and not paying for things. But state employees are required to pay for their health care. And then because they have a large number of them, they may have a lower cost. But I have never, having looked at the bills, and I know you are detailed enough to look at the bills that we are paying for insurance for state employees. They're not getting a benefit any more or any less than other people that get health care. So I just want to move this question along without vilifying the state employees that are receiving healthcare that they pay for.
Kathy, I didn't do that at all. I wasn't asking that. My question was specific to the assessments and how they're being assessed, because some of the assessments are only paid by certain companies. That's
Which
what
are
I'm trying to get at.
Employees, that's the boss of the state employees. That is not the state employee. That's all I'm saying, Tammy.
No, I
is
know. I think you're reading into something that I'm not saying.
There's a lot of weight right now, and I don't want to have the state employees to be vilified in this message. If you think that the state of Connecticut is not paying the assessment, that's a different discussion that we can all have. But that's not the state employees. The state employees didn't vote to not pay the assessment. And the state of Connecticut may have put something in a bill that you and I voted on, and whether we voted for or against it. But I just want to make sure that we are not vilifying the state employees themselves, who have nothing to do with the work that we do to get them health care. So if you want to say the state of Connecticut needs to be assessed like every other insurance company, I'm okay with that. I'm not okay with saying state employees are getting a benefit that they voted for, because they did not vote for anything and they did not do that. So we could, on this group, have the comptroller come in and we could ask him about that. Or we can talk to CBAC, who did the negotiations on things like this, and we could talk to them. They may or may not give us the information, but we have the administration who sits on that as the executive side of that discussion, and we could talk about that. But when we talk about state employees, it just means, and it sounds like, at least sounds like that to me and to people that are listening, that the state employees are getting a benefit that other insurance companies and state employees individually are not at the level of an insurance company. So I just
I'm
want to.
sorry you heard it that way, Kathy. I'm pretty sure I said state employee plan. If they were playing it, like but that was not my intent. You're taking it someplace that I didn't say, that I had no intention. I'm not talking about state employees specifically. I'm talking about the plan.
Thank you.
So,
Yep,
yes,
thanks.
no problem. I think you went someplace that I didn't go. I had another question, and I can't remember what it is now, because we just like devolved down into I don't know where. But oh, the question of, if we had a surplus in the past, that was paid for, right? We are sending out assessments every single year to the insurance companies. They are paying ahead of time. They're paying prospectively for immunizations. And when we have this buildup, is there a credit that goes back to the insurance companies for assessments that either expire or are not used or anything like that? Is there a return of the money for the PMPY, or is it just adjusted down? Because this year is an anomaly in it being such a low PMPY. So I'm not quite sure, because there's still a bill, how that works.
So we use any excess inventory to calculate the following year's projected budget. So in previous years, when we have had an excess inventory, we've brought the budget down, and we'll continue to assess the inventory as we set the next year's budget. The budget informs our request for funding from the immunization fund, but we do not have any input into the assessment that goes directly to the insurance carriers. So we just request what we need from the fund overall, and then the assessment is based off of that.
Okay. Thank you for that information. And I would say the last thing, I think we should possibly look at the state of Washington. They do their state assessments for immunization slightly different. The state pays for the initial immunization, and then as the doctors bill for it, the insurance companies reimburse that bill directly back to the state. That's two separate bills, one for immunization and one for the actual visit. because the way that this assessment works, it is assessed to every single member in the state of Connecticut at a PMPY perspective. So whether or not you are getting immunizations, you need immunization, it's being kind of socialized only over people who have insurance in that case. So we might want to look at broadening the pool, having the state purchase it, and then having the insurance companies directly reimburse the state for the actual vaccination, and continue forward with the same practice of reimbursing the physician's office for the physician. That way the costs are staying aligned to where they are, rather than being socialized over only the people who have insurance in the state of Connecticut. Thank you.
Wyatt Bosworth.
Thank you, Madam Chair. Thank you, Deputy Commissioner. I've been doing insurance for a couple of years now, and this is probably one of the most confusing issues I've come across. I could not find information online about this state or about other states. It's really difficult, so I appreciate your testimony. I have a couple questions, not about whether this is a program that should be funded. It obviously is a program that saves people money and improves the vaccination rates in Connecticut. My question is more about the funding aspect of it, which I know you may not have all the information in front, but I did have a couple of unique questions. The first being, so the CVP shifted its funding from a state appropriation to an assessment model in 2014, right?
I think actually it was before that. There was an assessment model before that where, from my readings, the money went into the general fund. Later, the insurance fund was carved out separately, but at some point in the earlier 2000 years, there was an insurance assessment.
Okay, and those assessments in the early 2000s were used to pay for universal vaccines?
Yes, they were used for vaccines. Yep, we weren't universal then. We were this universal select because we couldn't afford to purchase everything with those dollars. And so that was when that 2011, 2012 work group was established to figure out how could we afford to expand and be able to cover everything. And then after that, and the recommendations from that task force, I think that's when we then saw the bill in 2014.
Got it, thank you. So before assessments were levied on carriers, the state was unable to afford a universal vaccine program.
Correct.
Okay, that makes sense. And I just want to clarify for the group too about the funding. So Jane from the Department of Insurance sent over a chart a couple weeks ago that explains how this specific insurance or vaccine fund is capitalized. Specifically, it's each domestic carrier or domestic healthcare center doing health insurance business in the state, so not PNC. And then each licensed TPA that provides administrative services for self-insured health benefit plans. So I think as to the state employee plan, the question would be whether the TPA for the state employee plan is assessed and whether that TPA remits funds to the vaccine fund, right? And that's kind of the bulk of my concern is that, I'm looking at other states and we are unique in how we assess the insurance industry, right? Most states either don't have universal vaccine coverage, right? There's that sliver of children that don't go to FQHCs or are underinsured that privately have their insurance company pay for them, or they have to pay out of pocket for them. So, I guess what I'm concerned about is whether, section 19A7J, which talks about the health and welfare fee, whether that's being socialized enough amongst insured residents in the state of Connecticut. And I say that because most people in Connecticut get their health benefits through a self-insured plan, right? And typically self-funded plans are not taxed, right? Because this specifically with the premium tax, right? The state made a decision not to levy that out of ERISA preemption concerns. Even when you look at the public health fee under 19A7P, that only covers domestic insurer and domestic healthcare centers, specifically not third-party administrators. And I understand why you want to include TPAs, because you want to socialize that amongst all residents in the state, right, that receive health benefits. My question, and I don't know the answer to this, and I understand if you don't know the answer to this, is whether TPAs are actually complying with paying that assessment, right? And I think, Representative Nuccio raised a good point about ERISA plans that or exempt ERISA plans, like municipal plans, for example, like the state employee plan, the partnership plan, or just regular self-funded plans like, grocery store A or association B or captive insurance C, right? So my fundamental question is, if the state is having trouble, and I don't know if they're having trouble, but if they're having trouble getting those organizations to pay for the vaccine fund, right? Then maybe is that why most states just pay for this out of the general fund? And if so, that may be a thing we have to look at, right? Because it only makes sense, right, to have an assessment model if everybody's paying the assessment. So I don't know if you could comment on that or if you have anything.
I can comment. I
Yeah.
can't really answer your questions. I think you're raising some good points and some good questions. And the Department of Insurance might be able to answer the TPA question, but I think it's really up to the legislature who determined, how it was structured to fund and who to assess for the insurance fund. And so, I think certainly the task of this working group might help to inform some decisions down the road, but that's not really in our purview.
I'm going to ask some questions and we'll go back around to the group. Do you guys have questions? Okay. If the federal government is covering part of the program, does that mean that the actual immunization cost total is higher than what we're seeing here?
Yes,
And what is that total?
it's about 88 million.
Okay.
If you're asking about like how much VFC pays.
Yeah.
Yeah.
I wanted to ask about the staffing. So there's 3 staff that you've mentioned, but I wanted to know, where are the vaccines stored and how are they delivered? And are those services part of being covered by the assessment?
So they're stored at McKesson, who's our vendor. It's the same vendor that VFC uses. And so we're able to kind of keep all of that virtual inventory. So we have so many numbers per vaccine allotted to Connecticut, but they just have, vast warehouses of vaccines. And then when a provider places an order, it gets shipped directly from their warehouses to the providers.
And how are those storage fees and delivery charges covered?
Through VFC, actually, because we're able to
Through
use
what?
through the VFC fund,
Which is VFC?
the vaccine for children.
Okay.
The federal funds pay for our
so
Connecticut
federal
program as
dollars.
well. They're allowing us to leverage that. And so they ship both the VFC and the state paid vaccines in the same shipments, and they don't charge us for those. And they're paying the storage fees as well. So they're actually giving us that extra benefit.
And then once it is at a doctor's office or not, once a doctor is administering a vaccine, are they required to use the pooled vaccines, or can they purchase elsewhere and charge a customer for that a higher cost and their service?
According to the statutes we currently have in place, they are not allowed to purchase them separately. They must purchase them from the department if we provide them.
And how is that overseen and monitored?
Yeah, so we do site visits to all of the places because we want to make sure they're all stored properly. There's temperature requirements. Some need to be refrigerated, some need to be frozen. We need to make sure that they're properly documenting all the temperatures, how the vaccines are administered, things like that. So we go out and check all of our places on a regular basis.
And that is done by the 3 staff, or is
It's
that
done,
done by
some
the-
of it's done by those, but then other staff that are paid for through the federal contracts as well.
Okay. And is there a vaccine that kind of stands out as the most expensive, or is it? And I know you're sending us that list.
Yeah, no, let me just pull out my list. I was going to say from memory, I think it's the new RSV one, but
Okay.
yeah. Yeah. So the new RSV vaccine, the respiratory syncytial virus vaccine that came out that can be given at birth for infants is $395 a dose on the federal contract and $495 on the private.
Okay,
So
great. Thank you.
You're welcome.
Eric, did you have a question?
Just a follow-up, because I appreciate what Wyatt said. The issue is that sometimes determining what is one type of line provider as opposed to another is not as clear. Because classic P&C providers can provide group benefits, which do fall under health insurance. And classic life insurance providers can provide dental and vision, which also would fall under the definition. So I have seen and I would love to hear from Jane on this. I've seen the assessment bills from some of my members. And if they do provide health insurance, yes, their portion is going to be proportional to the amount for the rest of the state, but they will be assessed for that. So Jane, I don't know if you can add anything to that.
Sure. What the statute does is it specifies the lines of within health insurance that if a company is writing those lines, then they will be assessed. And so if you look at the law, this is 38A 469, and there's 5 subsections that are identified. So it's basic hospital expense coverage, basic medical surgery expense coverage, major medical expense coverage, hospital or hospital service plan contract, and hospital and medical coverage provided to subscribers of a healthcare center. So we would look at the lines that are reported by the companies and determine whether they would be subject to the assessments or not.
Sue Halpin?
Good afternoon, everyone. First, I want to say thank you to the chairs and to those that are sitting around the table, both today and previously, for engaging in this discussion, because I think it's really, really important to put a number of these things on the record. As you can see, it's a very complicated program, and it is something that the institutional knowledge, if not passed along, gets lost. And we worked very closely, and I would be remiss if I didn't recognize some of your former colleagues, Joan Soulsby and Ann Foley, who were very engaged in the development of this program as it's unfolded over the years. Again, I really appreciate the conversation and everybody answering the questions. I do want to say from the insurers, the carriers' perspectives, we do support the fund as currently created, providing everybody is paying their fair share, as has been discussed, around the table thus far. The savings that has been mentioned really comes in 2 parts. That savings assumes that everybody is paying their fair share, so that if they're not, that savings isn't necessarily materializing to those policyholders that are paying their premiums. So we want to make sure that that savings is being passed along based upon the number of people that are paying into the assessment. The second part, and I recognize you have to benchmark against something, right, to come up with a savings. I will say our own internal conversations and explorations don't put the savings as high as what's here, because obviously health plans negotiate discounts with drug manufacturers all the time. But we do agree there are savings, perhaps not as high as what's included in here. So I did want to put those 2 things on the table. And the last 2 points I wanted to make, I really appreciate you estimating the $52 and $55 million allocations for the future. One of the things that is most important to the carriers is to be able to plan accordingly and to budget appropriately for what they're putting together in terms of their rate submissions and things like that to account for the assessments that go along with this. So that open and continuing dialogue around your projections is really important going forward, before we see the governor's budget, in February. So I thank you for that. And then the other thing, and I recognize you may not be able to speak to this today, but the statute does provide for a reconciliation process. I'm not sure if that's what you're referring to, that reconciliation process, when you're looking at the savings that you've come up with, or if there's something more you can share with us in the future.
That's going to be part of my testimony, but yes, we do, once the as the deputy described, the responsibilities in 19A 7J, where OPM meets with DPH to determine the amounts necessary for the various pieces of, how much it costs to store and distribute the vaccines, purchase, store, and distribute vaccines to prevent Hep A and B, antibiotics necessary for TB and biologics, and to administer the program and provide services to collect all the up-to-date information. Then, once those amounts have been determined, OPM calculates the difference between the amount expended in the prior fiscal year for the purposes set forth above and the amount of the appropriation used for the purpose of the health and welfare fee. And in that same year, and informs the insurance commissioner through a letter to that effect. So, and this year's letter went August 27th, and it's in the package of materials that we provided. And the purpose of the calculation is to credit the assessed entities for any under expenditure that occurred in the prior fiscal year.
Thank you very much. Appreciate it.
Yeah, we can move over to OPM. I have some additional questions under DPH, but we'll ask them later. We can move to your presentation now, Judy. Thank you so much for joining us.
Sure, thank you. And again, I'm Judy Dowd from OPM, a section director in the budget division, and here to talk about OPM's role in the vaccine program. So I just went through the first one, which is to work to establish how much we're spending for those various components. And then to submit a letter to verify the assessment that would be necessary. And the second statutory responsibility is activities related to Section 19A 7N concerning the annual reconciliation. By October 1st each year, DPH and OPM develop and implement a reconciliation and expenditure projection process for the state's immunization program, including an accounting of the previous year's expenditures, the process and factors to be used in determining each future year's assessment, and the establishment of an appropriate notification process for the entities assessed under the account. So specifically, this process involves participation in an annual estimating conference made up of staff from DPH and OPM. That group meets to review the vaccine budget for the upcoming fiscal year, meet as needed to prepare the proposed budget when new vaccines are considered to be added to the Connecticut vaccine program, coordinate development and presentation of the governor's recommended budget and associated implementation language, if any is needed, and monitor program implementation and expenditures. So that is really OPM's role to assure that this work group of appropriate controls that are in place over the vaccine program and how seriously we take our responsibilities. Thank you for your time. And if you have more specific questions about the process or specifics of this year's meetings, we are happy to provide that additional information.
Great. Thank you, Judy. I wanted to dive into section 19A-7P, which is the needle and syringe exchange, children's health initiatives, aid services, breast and cervical cancer detection and treatment, X-ray screening and tuberculosis care, venereal disease control, and just understand the history of those costs being part of the insurance fund.
We were under this understanding that today's discussion was solely going to focus on immunizations and the immunization fund. So we're happy to answer any questions outside of that about the larger insurance fund in writing after the meeting.
Okay. Any other questions? Representative Walker, did you have a question?
Yes, sorry, I'm trying to move my mouse around fast enough to get there. Yeah, I just want to continue on because I had asked about the the staffing that was with the immunization, and and I was told that there were more staffings involved in the information that OPM was going to provide us. So could you, I'm assuming that it's the staffing in the other parts of the discussion that Judy has presented to us, but I just want to make sure that that question in.
Are you asking about the conference committee, the staff that meets to do that, or staff?
Staff, maybe I misunderstood what I heard, but I was led to believe, or I thought I heard that the 3 staff from 2015 has expanded, but in other areas that you were going to expand upon or comment on. So is it part of what you just outlined that you said you're going to report to us later on about, or is it more on the other areas of the immunization costs?
Yeah, we can send a full breakdown of the DPH budget related to the immunization and insurance fund, which will include other staffing costs that are funded through those mechanisms at DPH.
Okay.
But just to clarify, there's on the immunization side, there's 3 staff that are funded through the immunization fund. There are
Mhm.
other staff at DPH that support the immunization program, but they're funded through our federal dollars.
Oh, got it. Okay. Okay. Thank you. Thank you very much.
Sue Halpin?
Hi, thank you again. Just a quick question. Are there any children's vaccines on the horizon to be added to the fund?
Yeah, that's a great question because I think after you said, oh, you were happy to hear the estimated numbers for fiscal year 25 and 26. And I was like, well, that always it was with a caveat of what might be in the pipeline, because just this last year we added COVID because it was no longer federally covered, RSV, and then there was a new updated pneumococcal vaccine for children to replace an older one, and that was more costly. So currently right now, I don't think that there's anything close to being approved in the next 6 months or so. But then for the following fiscal year, I'm not quite sure. There are always kind of, updated vaccines. Well, they are working, I think, on a meningococcal vaccine that will cover all 5 strains in one vaccine. So that might be something coming down the pipeline. So
And just one follow-up from the earlier conversation. I have received confirmation that the state employee plan does pay the assessment. But I think the question is really an important one, just to make sure that everybody out there, whether it's a plan that's administered by a Taft-Hartley plan, or if it's a plan that's administered by an out-of-state TPA, et cetera, that everybody is paying for their individuals under their umbrella, so that the cost is as widely socialized as possible. So thank you.
Any other questions, comments? Seeing none, we will adjourn.
Well, let's set the next meeting. Which we're not
Before
setting
adjournment.
until after November 5th. Just saying. I don't know. I am not commenting on it, but I am much akin, I have no open spots in my calendar.
So November 6th at 8:30 a.m.
Something along those lines.
Okay, how about the following week? 11th is Veterans Day, maybe Tuesday or Wednesday, the 12th or 13th.
The 12th.
The 13th.
The 13th is fine during the day.
What do you-
I have 4 or 5 meetings that night, but
Okay, we'll pick something like 11 a.m., 10 a.m.
11.
11 a.m. on the November 13th. I was gonna be in Tahiti, but I guess not.
It's a choice, Tahiti or here,
Right.
and if you say here and you're coming, I am going to have you checked
Oh.
out. because-
It would be fun. All right, we will adjourn. Thank you, everyone.